There we go.
Hi, everyone. Thank you so much for joining us this afternoon for this special webinar for our NYPC Patient Alumni Network. The topic is Update on Proton Therapy, The Future is Now. And our featured speaker is our Chief Medical Officer, Dr. Charles B. Simone. So before I introduce Dr. Simone formally, I wanted to go over a few things. First, to let you know that we're really excited by the turnout for this webinar. We have not had one in a while, and there'll be more to come. For those of you who have not joined the Patient Alumni Network and you've been a patient here, you can join via the page on our website. It's called Alumni Network, or reach out to me at the Proton Center at any time. My name is Melissa Weistuck. I'm the Marketing and Communications Manager here. We truly value the friendship that we have with all of our alumni, former patients, and we are excited to be planning into 2026 some more opportunities for you to be involved and be connected with us at the Proton Center. And now it's my very great pleasure to introduce my colleague and our Chief Medical Officer, Dr. Charles B. Simone. Dr. Simone, as many of you already know, is an internationally recognized expert in proton therapy, in reirradiation and stereotactic body radiation therapy using both proton and conventional photon radiation therapy. In addition to his role as our Chief Medical Officer and a research professor, Dr. Simone is a full member in the Department of Radiation Oncology at Memorial Sloan Kettering Cancer Center. He is a sought-after expert in treating lung cancer and thoracic malignancies, delivering care with great skill and the utmost compassion for each and every one of his patients. During his career, Dr. Simone has published literally hundreds, I think it's over 650, scientific articles and given equally as many lectures around the world. I'm really excited that he will share some of his knowledge with all of you today. So I'm going to turn it over to Dr. Simone. Thank you.
Great. Thank you very much, Melissa. Thank you, AJ. Welcome, everybody. I hope everyone's having a good evening. Thank you all for taking the time out on an evening to hear us talk today. I thought I'd give a little bit of background on our center. Obviously, many of you are alumni, but give you a little bit more information on how the center came to be and really what we're doing here on a day-to-day basis. And then go into, how is proton therapy different than traditional radiation therapy? And then once we cover those kind of bases, we'll go over, I think, what are 5 very innovative ways that proton therapy and radiation in general is changing for the better and advances on the horizon. So we'll talk about the future is now in that regard. Disclosures are NIH funding. So the first part about New York Proton Center. We're a consortium co-owned by Memorial Sloan Kettering, Mount Sinai, and Montefiore. The center opened in 2019, but it was back in 2010 that those 3 institutions came together and applied through the Department of Health to open a proton center. There was a competitive process that required a certificate of need from the state. Our project was selected among the many that applied to be a demonstration project where the Department of Health would not consider other centers for a 10-year period. How do we get protons and what do we have technology-wise in our center? Well, we have a cyclotron. It's this essentially 10-foot wide device that's tens of millions of dollars. It accelerates particles 2/3 of the speed of light in negative 425 degrees. So very precise, very sophisticated technology. From there, from this machine, it siphons the radiation down a beamline into each of our treatment rooms. And so this is the cyclotron here. The radiation travels across the beamlines, and we have 4 treatment rooms, 3 of which are gantries where the machine rotates around the patient, 1 of which the patient moves around the machine, but the machine stays fixed. So 4 different treatment rooms. We also actually have a 5th room that we use dedicated for research, mostly on the physics side to enhance and improve the way we deliver the treatment. Very, sophisticated technology compared with a regular radiation machine where a machine's about 10 feet high. It generates all of its own radiation and is a standalone. Here again, we need this to generate and go into each room. Each of these gantries, for instance, are nearly 300 tons and rotate a total of 3 stories, above a story and below a story from the treatment floor that you were on. And then, our technology, even among other proton centers, is pretty novel. So there are now 48 operating proton centers in the country. Among them, we have the most sophisticated type of proton therapy. There have really been 3 generations of protons, and we have the most advanced, so we can really sculpt dose around normal tissues much better to protect side effects. We can treat bigger tumors and bigger field sizes than any other proton center in the country. And then we have what's called co-beam CT. So it's essentially volumetric imaging, like you're getting a low-dose CT scan each day before treatment. So we can actually directly visualize the tumor and line you up to the tumor for treatment. Many other proton centers rely on marks on the skin as the only way to line people up, or X-rays and using bones as a surrogate for where your tumor or your tumor bed is. But we can directly visualize the tumor and treat in that way. And then on site, we have PET scanner, MR scanner, and dual energy CT scanners. Many of you were treated here at the center. We have 26 physicians that provide care at the center. Really are a tremendous group. Many of them have significant proton experience even before our proton center opened. Many have treated at other proton centers. In fact, most did. And then we have leadership roles really across every society. There are 4 main groups that are involved in proton therapy research and innovation in the country. And we have leadership roles in all of them. So the Proton Collaborative Group is the largest research society of proton therapy. I'm the president of the board of directors for them. The National Association for Proton Therapy is a big advocacy group helping with insurance authorizations and policy around proton therapy. And one of our physicians chairs the physician group for them. NRG Oncology is a cooperative group funded society that NCI contributes to, that essentially charged with advancing research in oncology, and particularly radiation oncology, some of which is proton therapy, and I chair the proton group for NRG Oncology. And then the PTCOG is the main international proton group, and we have many people in leadership positions there. So it's really an exceptional group of physicians, but as you probably have surmised, it's not just the therapists that are treating you, it's not just the nurses that we're helping manage symptoms and the physicians, but we have a big extended team. We have physicists, we have dosimetrists. They help generate the plans that you received. They help to quality assure them and make sure they're safe. We were able to recruit all of these positions, physicists, dosimetrists, therapists, nurses from other proton centers, to really have a tremendous amount of experience. And we've really, in addition to patient care, one thing that we pride ourselves on is education and training. We've wanted other centers to be able to have the similar type of experience that we have. We know not everyone's going to be able to go out and recruit top physicists, top physicians from other proton centers, but we wanted to be able to help train other proton centers. And in the last 4 years, there have been a little over 24 proton centers that have opened in the world, and we've trained 22 of them. So the large majority of centers that have opened in the world, we've actually done all the training for. We're close to 6,500 patients treated since we opened our doors in summer of 2019. And we're really treating the most complex case mix of any radiation oncology center, proton or otherwise, in the world. A lot of advanced head and neck cancers. This is our most common disease we treat, but you can really see we're kind of treating everything. A large portion of brain and central nervous system tumors, breast cancer, lung cancer, pediatric cancer, prostate cancer. We actually treat 2/3 of all pediatric cancers in the city. So, large referral base for our children. And then we'll talk about reirradiation as one of our 5 innovations, but nearly half of all our patients that we treat have had prior radiation and are coming to us for a second chance at cure. So a very quick, what is radiation and what are the different types of radiation before we focus on protons and then the innovation. There are 3 main pillars of cancer care. One is surgery. One is systemic therapy. That's chemotherapy, but it could be targeted therapy, immunotherapy, and then radiation therapy. And some people only need radiation therapy. Some people may need all 3. Some people may have different treatments at different courses of their cancer journey. But many times these treatments are used in conjunction in a way to best sterilize the cancer and kill disease. So how does radiation work? Well, there's internal radiation. You may have heard of brachytherapy, that's putting radioactive seeds inside the body. But the large majority of radiation that we give is external radiation. And that's what we do here with proton therapy. The other types of external radiation are photons. That's the most traditional way. It's an X-ray or gamma ray, and then electrons for very superficial targets. But all of them work the same way. All these external radiations cause ionization and damage the DNA of tumor. So essentially, radiation passes through the DNA of the cancer and damages it. When the cancer tries to fix that damage, it can't. Normal tissues have a very good repair mechanism. So if there is a damage, the body can heal. Cancer cells don't have that same repair mechanism. So if we cause a damage in the DNA, the double-stranded DNA that you may remember from middle school biology, the cancer cells will ultimately then die. And that's really the way that radiation works. So the types of radiation, historically, it was delivered with just two-dimensional radiation. You really shoot in one direction and everything along the path gets treated. 3D radiation really replaced that, and that's really giving still straight lines of radiation. You can see kind of high doses straight lines, but you can conform all to converge in a shape. So for instance, this is a patient getting treated for prostate cancer. This is the prostate gland. Where all these beams converge, the red is the high dose radiation, and that's the target, and that's what we want. The unfortunate part of 3D radiation is there's pretty significant radiation dose going through all of these beams. So that's really where patients can get side effects through the hips, this is the rectum, the bladder above. So the field had moved to, in many centers, intensity modulated radiation therapy or volumetric radiation therapy, where we can essentially spread out the radiation a bit more. So we're still giving that high dose to the area that we want, but now it's lower doses to the rest of the body. And that's good in that it's a lower dose, it's not quite as toxic to the normal tissues, but as you can see, essentially the entire body in the region being treated gets exposed to radiation. You can do it very sophisticatedly. You deliver radiation while essentially the machine is blocking different areas, but the reality is radiation is still being delivered to a big area. The last thing before protons is something called stereotactic body radiation. And this can actually be done with protons or photons, really just the concept of delivering very, very high doses of radiation to a relatively small area. And instead of getting radiation every day, Monday through Friday for 4, 5, 6 weeks, it's literally just a couple of days of treatment, typically 3 or 5 days of radiation. So very, very high doses of radiation where we can visualize the tumor directly and treat it. And essentially you can see kind of the radiation machine arcing around an area to treat an isolated target. What makes proton difference is with regular radiation, you can kind of think of it like a flashlight. If you see my mouse moving this green, the radiation leaves the head of the flashlight and you can see it's actually getting less bright because as you get further away from the source of the flashlight, the radiation, the intensity is being attenuated. You get less and less radiation. It hits the tumor that you want to treat, but then it keeps going out the other side. As you can imagine, photons, X-rays are a very light particle. There's nothing to stop them, just like a flashlight. You can't see as much 100 yards away, but there still is some light coming out. So it's going through and through the body. With proton therapy, because it's a heavy charged particle, we can actually use magnets to set where the radiation is actually being deposited. So now if we're trying to treat this tumor, we can send radiation in, we can hit the target, and all of the radiation stops at the target. So now all of the healthy tissue gets completely spared of radiation. So in this case, the brainstem, the esophagus, all that are in front of the brain here are completely spared and would not get any radiation. Even among protons, different centers have different technologies I alluded to before. We're very fortunate we have the ability to exactly contour the shape of a target. And you can kind of think of what we have pencil beam scanning as painting like an old-fashioned typewriter would. You treat a line down, you treat a line up, hit the enter key, treat a line down, hit the enter key, treat a line up. So we're doing the exact shape of the target. Historically, proton centers couldn't do that, and they would just give a lot of dose in this region, and they would stop, which is good. So all the normal tissues over here were protected, but they couldn't really conform to the exact shape of the tumor, and so more normal tissues beyond and in front of the tumor got treated, whereas we can really spare normal tissues to a better degree. And how that looks, some of our adults with central nervous system tumors, many of our children with central nervous system tumors need what's called craniospinal irradiation. The entire craniospinal axis treated, both the brain and the fluid that's bathing the spinal cord. This is the spinal cord here. With traditional radiation, the radiation comes in from the back, but then goes through and through the body. And so all of the normal tissues in the front gets exposed. So as you can imagine, that's the heart, the lungs, the GI organs, the reproductive organs. With proton therapy, you can send the radiation in, you hit the target, and all the radiation stops where you want. So now you don't have any dose to the lungs, you don't have any dose to the heart or to the reproductive organs or to the GI organs. So the side effect profile is just day and night different for this type of treatment. And because we can better sculpt beyond the target with the type of protons that we have relative to older proton therapy, we can exactly hug vertebral bodies that are in like an S shape, and that can help prevent, for little kids, growth delays and other problems that happen even with first generation proton therapy. So why use protons? We can better protect normal tissues that can reduce toxicity. We can more safely treat tumors that may have not been safely treatable with photon therapy to increase the chance of cure. We can treat to higher doses and be more aggressive without causing more side effects, so we can again increase chance of cure. Because much of what we do, as I alluded to, is not just radiation. Many patients get concurrent chemotherapy or they've had surgery before radiation. Each of those toxicities of each of the modalities add up. And if we can reduce the toxicity with radiation using protons, patients can tolerate multimodality therapy better and have a better chance at cure. And then reirradiation is a big part of what we'll talk about later. And this is just visually, for our brain patients. If we're trying to treat this tumor bed here, proton therapy really just treats around that area. The color is, of course, where the radiation is being deposited. The entire rest of the brain gets literally zero radiation. Even with the best of photon plans, you can see it's very conformal and that the red, the high dose, is where we want it, but the entire brain is getting some radiation. And that's what leads to neurocognitive and other complications. Head and neck, same thing. This is with the best technology of IMRT, the photon therapy. With proton therapy, we're just treating the target and sparing the oral cavity and the rest of the head and neck area. This is a tumor in the chest, right in front of the heart, very difficult area to treat. You send the radiation in, it's a thymic tumor. Radiation stops. This is the heart here. All the radiation stops before we expose the heart to what would otherwise be here, high doses of radiation. This is the esophagus, the spine. They're also getting treated, but literally zero dose with proton therapy. Breast cancer is a great indication. With breast cancer, with photon therapy, we end up treating a good portion of the heart, whether it's right-sided or left-sided treatments. If it's a node-positive case, proton therapy can literally send the radiation and hit the breast or the chest wall, and we completely spare the heart, including the coronaries, which can lead to long-term heart problems in patients. So I put this together several years ago, just showing if you compare protons to photons across most every disease site at this point, we have data showing that proton therapy can either reduce high-grade complications, can better improve survival, or can better preserve quality of life. So, most every disease site can benefit. Now, does every patient benefit? No. Most estimates say about 30% of patients would have a very clinically meaningful benefit to proton therapy. But some cancers we do exceptionally well with traditional radiation therapy, high rates of cure, low rates of toxicity. Those patients generally don't need proton therapy, but for many of our challenging to treat tumors, you can see across the board proton therapy can really be a benefit. All right, so I'm going to focus on 5 kind of unique aspects of the future is now. The first is something we've been doing for a while, but kind of the rest of the country and world are starting to catch up, reirradiation, treating patients for a second time in the same area. And as we started to see that systemic therapy is improving, immunotherapy is widely used, targeted therapy is widely used now, patients are living longer even with metastatic disease, and local control, where the cancer started, is increasingly important. But we know that patients have progression at their sites of where the cancer started commonly, even after definitive therapy, including prior radiation. Once that happens, if the cancer comes back after prior radiation, they're generally not great options. Systemic therapy has been the standard of care, but it's not a curative treatment. The only way to cure most cancers is either surgery or radiation. And surgery is typically difficult after prior radiation and usually doesn't control microscopic disease with surgery alone. You generally still would need more radiation. So doing radiation a second time or reirradiation to the same area can help control symptoms if there are symptoms. It can control the tumor locally, and in doing so, if we control the tumor locally and that was the only site of recurrence, we're curing patients that previously never had a chance of cure. So that's why it's such a big focus of what we do here. 43% of all the patients we treat are reirradiation. And these are patients coming from, of course, our three partner institutions, Memorial Sloan Kettering, Mount Sinai, and Montefiore, but from all over. Patients are referred regularly from Columbia, NYU, et cetera, because it's not safe to necessarily treat a second time around with traditional radiation, but we can do it more safely with proton therapy. And why is that? Well, a lot of the normal tissues already receive their maximum dose that they can receive with our first course of radiation. But if we can completely avoid giving radiation to a normal tissue because all the radiation stops at the tumor and doesn't go into those normal tissues, now proton therapy can better safely retreat a patient and can allow for higher doses in the reirradiation, which really directly impacts overall chance of cure. So we did an analysis where we looked at thoracic tumors, head and neck tumors, and pelvic tumors, GI tumors, and we compared proton and photon therapy. And across the board, the consensus for each of those was proton therapy is the safest way to treat this analysis that I led a few years back. We also did a systematic review where we looked at toxicities of reirradiation for protons and photon therapy. I led this as senior author. And across essentially every disease site, proton therapy was the safest way to retreat and offered the best chance of recure. All right, so what's the second kind of future is now? That's really looking at the role of radiation therapy in metastatic disease. And this can be applied with protons and photons. There's good reason to use protons in this, but we're starting to see that more and more patients are being referred with what has historically been stage 4 metastatic disease only receiving systemic therapy. But now we're treating with essentially curative or definitive intent for many of these patients. And I'll give an example. This is an interesting case. A patient was getting a targeted therapy. At diagnosis, they had pretty extensive disease. So, the cancer started here, spread to here, spread to here. They were on targeted therapy and everything melted away. So they had a great response to systemic therapy. But as I alluded to before, the only way to really cure cancer for most solid cancers is either surgery or radiation. So targeted therapy, chemotherapy, they're generally not curative by themselves. After 9 months, one area started to regrow. But everything else was actually doing well. This was the only isolated site that started to regrow right where it started earlier. So at that point, you have a couple of options. You can try to increase the dose of the drug, but that's generally pretty toxic. You could switch, instead of doing this drug, you go to chemotherapy, but there's also not a guarantee that chemotherapy works. And the drug seems to be working everywhere else in the body except this one little area. So what we're increasingly doing is actually using radiation almost like spot welding, if you think of it that way, where we can target in very small areas, stereotactic proton therapy. We treat this one area and patients can stay on the same drug. So a drug that historically they would have to come off after month 9, now patients are able to stay on that drug for 2, 3, 4 years without having to switch if they were tolerating the drug well. And some patients, if this was their only site of disease for what's called oligoprogression or oligometastatic disease, where they're only progressing in 1 or 2 areas, or they only have 1 or 2 sites of metastatic disease, if we treat both of those sites locally with definitive therapy, radiation or surgery, we can actually cure some patients that have metastatic disease. So it's a very exciting area, and we're really making a dent in that area. There was a study that we did at Memorial Sloan Kettering as a phase 2 randomized trial, 100 patients with lung cancer and breast cancer, where we treated up to 5 sites of metastatic disease that were progressing on systemic therapy. We randomized them to either just continue systemic therapy or systemic therapy with radiation, the high-dose stereotactic radiation. And we improved progression-free survival, meaning until new cancer formed or needing to switch other therapies and ultimately survival, 5 times higher if we did radiation to these sites of local disease. So patients did dramatically better with lung cancer if they got local therapy, even with metastatic disease. And this is kind of the next future of treating metastatic disease. This is combining that high-dose radiation with immunotherapy. This is a really neat case. This is a patient when I was at University of Pennsylvania treated. They had a very symptomatic lesion in the pelvis. They got palliative radiation while they were getting immunotherapy, really just to help with the pain. And you can see this is the post-treatment down here. That lesion responded very well to radiation, as we'd expect. Radiation does well locally. But what was really neat is they had two other sites in their body, a site in the liver and a site in the abdomen. Both of those were progressing even on immunotherapy. We treated just this one site, and these other two sites responded. And that's called the abscopal effect. Essentially, abscopal meaning an effect away from an area, ab away. Essentially, if we just treat this site, we can see responses in sites farther away from what we treat. And we think that radiation is really ramping up the body's immune system locally. It can stimulate the immune system. And now people that are on an immunotherapy that's helping target and ramp up the immune system, people can have good responses in the rest of their body. So this is a really exciting avenue, and we're seeing many studies like this now come up. This was a study across town in New York here with almost 40 patients where they saw if you treat one site with radiation, about 1 in 5 patients have responses to the other sites in their body, even if they aren't targeted. So it's a really exciting time to think about combining radiation therapy with immunotherapy. And then the last broad picture I'll talk about is mitigating toxicities. And there are 3 ways to do that, and I'll talk about each of them. The first one I'll talk about is radioprotectors, essentially giving a drug to try to prevent a toxicity from radiation. So I've done a lot of work with a drug that was discovered by the Department of Defense called Bio 300. It's a drug that essentially has antioxidant properties, like akin to a strong multivitamin. But in doing so, it allows for better DNA repair of damage from radiation. Now, tumor, again, doesn't have the same repair mechanism, so the drug isn't preventing damage to the tumor, but it's preventing the normal tissues from being damaged. It can be taken orally, and in doing so, it can protect the normal tissues better from radiation toxicity. So we did a phase 1/2 trial, specifically in lung cancer. This is a multi-center trial that I led. We published it last year, where we showed that compared to the best historical controls from NCI-funded research, our trial, we had fewer patients with pneumonitis, inflammation of the lungs. We have essentially no patients with scarring of the lungs after treatment. And then hematologically, so red is the historical and blue is our trial. You can see a high percentage of patients, about a third of patients or more, had anemia with regular radiation without the drug. But when we added the drug, very, very few had anemia. Similarly, we cut problems with white blood cells, problems with platelets, all significantly less. Symptom-wise, patients did better with dyspnea, and their quality of life was better preserved if they receive this drug. So it's an exciting thought that if this is borne out in larger trials, we may now be able to combine proton therapy with a drug, and you get the best of both worlds. The physical properties of protons that stop, and now we protect the normal tissues that way, and this drug that also helps to protect the normal tissues. The second way to protect normal tissues is something called flash. It's essentially delivering ultra high dose radiation. A regular photon X-ray machine delivers a dose rate, how fast we deliver the radiation, at a fraction of a gray per second. So you're on the table for quite a while to deliver your radiation dose. With proton therapy, we deliver radiation at around 1 or 2 gray per second. But what we found is if we dial up the dose rate to, say, 100 gray per second, there may be different biology happening in the body than traditional dose rates of even proton therapy. And what we've seen now in quite a number of studies, small animal, medium and large animal, as well as cell studies, is if you deliver this ultra high dose rate, it's almost like the body is not perceiving that it's getting radiation to the normal tissues. So the normal tissue is better protected, but again, the tumor, it doesn't have the repair mechanism. The tumor is still dying at the same or maybe even better effect, but the normal tissues are much better spared. So across all these animal studies, we've seen less skin toxicity, less lung scarring, less cognitive problems, better GI repair from damage, not damaging stem cells, so patients can recover much easier across the board, across all disease sites. So it's been very exciting. This can allow us to, one, either increase the dose of radiation that we give to increase the chance of cure without increasing the toxicity, or giving the same dose, same chance of cure, but now a lot less risk of side effects to patients. This is an example of a study that was done. You can see, I'll just kind of focus on this side. This is a patient that got, a pig trial that got single radiation doses, 34 gray, 31 gray, or 28 gray. Grays are unit of measurement. After that, you can see this is 36 weeks after, there's still a lot of scarring in the tissue of the skin, essentially permanent ulcerations in the skin. If you deliver that same 34, 31, or 28 gray at an ultra high dose rate, the skin really, you can see slight changes, but the skin is dramatically healed. And what's happening underneath the skin, uh, with flash, the ultra high dose rate, this looks very similar to somebody that never got radiation. The phenotype of these two are very similar. You can see here, if the radiation is delivered traditionally, we cause a lot of damage and a lot of disruption to what's underneath the skin and the rest of the normal tissues. So flash has a way to potentially protect all that. How still needs to be investigated. There are a lot of hypotheses of how it's working, but it does seem to consistently be working. So that led us to, I actually wrote the first ever clinical trial in this that was conducted in the University of Cincinnati. And we published this about a year or so ago, where we treated 10 patients with this flash dose rate, and patients did very well. Now, the trial was to look at feasibility of delivering these ultra high dose rates, but this will now lead to future trials where we hope that we can help to mitigate toxicity in patients. And the other nice thing about flash is not only does it help to prevent toxicity, we think, but it may also allow patients to get treated in just a single day, as opposed to 5 days or as opposed to 25 or more days, which would be really neat. Now, the one thing that we've done a lot here on the physics side is traditionally flash is delivered through and through the body. So you don't have that same benefit of protons where it stops. We're combining the benefit of protons where the radiation comes in, hits the target, and stops with ultra high dose rates. And we now have been the first group to figure out how to deliver this. And so now I think we can really marry the technology of proton therapy with the ultra high dose normal tissue sparing and have the best of both worlds to protect normal tissues. And then the last thing that I'll talk about, again, another way to protect normal tissues is something called spatially fractionated radiation therapy. Traditionally, what we do when we treat a tumor is we treat the entire tumor to the same dose homogeneously. Spatially fractionated radiation therapy is essentially just that. We're spatially fractionating the radiation so that some areas of the tumor have these high doses of peak doses, and some areas of the tumor have a valley dose or a very low dose of radiation therapy. So we're not treating everything homogeneously. We're intentionally creating areas of very high dose and very low dose. We typically do this in just a single dose of treatment to a very bulky, very aggressive tumor. And we've seen that we can have profound responses to the tumor without causing a lot of toxicity. So what this looks like, instead of the earlier pictures I showed you, was kind of red all over the tumor. This is the tumor here. This tumor is pushing against the heart over here. Here now we're giving red high dose radiation in these peaks, but then we intentionally are having little valleys in between. And so this is how the distribution looks. And in doing so, you can see what was this big mass here. This is the tumor that I'm kind of outlining. Just days after we treated with this high dose radiation, you can see it shrunk dramatically. So we can have faster responses and more complete responses in just a single day of this spatially fractionated radiation therapy. And it's generally very well tolerated because potentially a lot of different effects. So I'm not going to go into the mechanisms of this, but this is a little bit more understood than flash. We think that there's a lot of immune response and more of the abscopal effect that I mentioned earlier if you deliver radiation with these peaks and valleys than if you homogeneously deliver it. And we cause less damage to the vasculature if you deliver it in this way as well. And again, proton therapy is a perfect way to further take the concept of spatial fractionation. Spatial fractionation with traditional radiation is still going through and through the patient, but proton therapy, you can have these peaks and valleys and still stop. So now we're getting less toxicity along the path and no toxicity beyond the path, and still having very robust responses in the areas we treat. So this is a big interest in the field of radiation oncology. Many trials have been underway in the last few years. I led as senior author this international consensus where we said, what is the best way to deliver this very advanced technology and how should it be done on clinical trials? So we're very excited for the future of what this field can hold. So in conclusion, radiation is one of the pillars of oncology along with systemic therapy and surgery. It has a curative role or a symptom improvement role for many cancers. There are many types of radiation therapy. The field progressed from 2D and 3D radiation to intensity modulated radiation therapy with photons or stereotactic body radiation therapy in just a couple of days with photons. But proton therapy, because of its unique physical properties, stops. And so we can better protect the normal tissues that can lead to fewer side effects, better preservation of quality of life, better tumor control, and better overall survival. Many patients, unfortunately, can have recurrences of their tumor during their cancer course. If they've had prior radiation, it's typically difficult to retreat those tumors, but proton therapy can be a better way to treat and offer new chances of cure in patients that otherwise wouldn't have had chances of cure. We're increasingly seeing a role for radiation therapy in patients even with metastatic disease with a curative intent to control disease long term, and that could be in combination with immunotherapy. And then there's a lot of interest, of course, in mitigating, reducing toxicity even further than what just proton therapy can do. And that could be combining proton therapy with radioprotectors. It can be delivering this ultra high dose rate flash, or it could be delivering proton therapy in spatial fractionation, all of which, certainly more work needs to be done, more trials, but it's a very exciting time where I think the future is improving outcomes while still reducing toxicity from what we have today. Well, I appreciate everyone's time. I wish you all a great evening and thank you very much for joining.
Thank you all so much, and look forward to more programs you'll be hearing from us.